I retired from being director of the Student Health Service at University of Denver in 1985. It was not long after that I started writing the story of my mother's life as a family project for the sake of my children and grandchildren. And I also began traveling abroad to visit countries that had single-payer universal health systems because I wanted to know on a national basis how countries funded and implemented and provided health care, how they delivered the services to handle everyone living in their country. And there were many, many countries to choose from. All other developed countries in the world, besides the United States, do have a system of universal health care. And my goal was to learn how the various countries did it and what the strengths and weaknesses of their systems might be. And it was fascinating. In Norway, I was very impressed with their telecommunications network. Every physician in that nation, even far-flung north limits of their country, was connected with the teaching hospital in Oslo. And they had access to 24-hour-a-day, 7-day-a-week consultation in all specialties. We went down in the basement of the teaching hospital in Oslo and saw the room where the messages were coming in, patient exams, x-rays, EKGs, biopsies, cultures, all sorts of data. And immediately the technician on duty at that moment would connect them with a specialist whose evaluation and advice was needed. 24 hours a day, 7 days a week, specialty consultations, no matter where you were in any remote part of the nation. That was fantastic, and I thought, that's something we could do too if we had universal health care. It would reduce the costs, simplify the transport problems, and give the rural physicians the expertise that they needed to deliver quality care. In Finland, I was very impressed with their administrative system. Instead of having a national bureau or committee overseeing the nation, they divided the country into population units of 200,000 to 250,000 per administrative unit. And each unit was given a budget annually based on the demographics. They included the number of people served, the incidence of chronic diseases, the incidence of mental illness, of cancer, and disabilities, and any other conditions that might be more costly. And the lump sum of what was estimated needed was revised annually. And a volunteer committee of 7 citizens decided how to spend those dollars for the best implementation of care to everyone in their jurisdiction. And when you have the administration of the financial resources in the hands of the people being served, you have very good decisions being made. And I thought that was a terrific idea. You don't need a bureaucracy to administer such a system. It can be administered locally as long as the funds are allocated in a fair and equitable and realistic way to meet the needs of the people being served. My trip to